Good afternoon, everybody. I see we're just a minute after 3 o'clock. Please excuse my voice. I'm very glad to see that everybody is here and we are ready to go. We have approximately 82 people on the call, and it's really, really lovely to see so many international people from Isaac, Singapore, as well as I think the UAE, and very many different countries. We are all very excited for the talk today, Cissy, and we're really looking forward to learning more from you. So if I can just give them a short background about you. Cissy Cheng is a doctoral student at the University of Texas in Austin, where she is mentored by Dr. Rajinder Kaul. As many of you would know, Professor Kaul is actually an extraordinary professor at the Center for AAC, so we're very grateful for that collaboration. Cissy has completed her BA in Linguistics at Fudan University and has an MSc Speech, Language and Hearing Sciences at Boston University. She's got clinical experience and has also published some very interesting papers that I've read of yours, Cissy, in terms of autism, dysphagia, voice disorders, as well as cognitive conditions. Cissy brings with her a diverse background in terms of her research endeavors, and her research interests include speech production training utilizing biofeedback, AAC interventions for individuals with aphasia, and improving patient-provider communication in intensive care settings. In her spare time, Cissy enjoys running and reading with her little one. You sound like a very, very busy person, Cissy, so we really do appreciate you making time, despite all of your commitments, to come and share your work with us, with a specific focus on AAC and its implementation with people with aphasia. So I'll be quiet. I just want to say that we will save the questions for the end, Cissy. We will take them either by audio or people can put it in the chat. And you have about an hour to present, and then we've got about 10 minutes for questions and answers. So we're looking forward to it, and thank you very much for your time. Cissy, I think you just need to switch on your mic.
Oh, I'm so sorry. I was just saying. Thank you. Yeah, I was just saying, like, thank you so much, Dr. Dada, for the introduction, and also thank you so much for having me today. As Dr. Dada said, I have some experience working with people with aphasia, and also I have some research experience working with Dr. Cole, and to learn about how to use AAC strategies to help aphasia patients to improve their participation in life and improve their language competencies. So very glad to be here today to talk to you about how to implement AAC strategies in aphasia intervention. Let me share my screen. All right, share screen. Okay. Can you guys see my screen, the slides?
Yes, we see it clearly. Thank you.
Okay, great. All right. So today I'll be talking about how to implement AAC strategies in aphasia interventions, some strategies and considerations. Okay. So first of all, we have no financial disclosure or conflicts of interest with the presented materials in this presentation. So here are some of the primary themes I will be talking about today. First of all, AAC and patients with aphasia, why we can use AAC strategies for patients with aphasia, what benefits can it bring to them, and why it is important to use AAC for patients with aphasia, and some rationale behind AAC strategies for patients with aphasia, and some considerations we have to keep in mind while designing AAC interface for patients with aphasia, and some strategies like sample activities for integrating AAC in aphasia intervention. So first of all, AAC and physiology. So as we all know, like aphasia refers to a condition that affects a person's ability to speak or write. It is typically caused by the damage to some of the language areas of the brain due to a stroke, some traumatic brain injury, or other neurological disorders. So some symptoms of people with aphasia, they might have difficulty finding words, have trouble formulating grammatically correct sentences, they mixing up and substituting words or using like words made up by themselves, or they face challenges with both comprehension of both written and spoken language, and some of them have difficulty reading and writing. So like aphasia not only affects their language abilities, but also has significant social implications. So here are some of the key social aspects of aphasia. So like it can make them feel very frustrated, both the patients and the caregivers. It can make them like feel like socially isolated because, for example, they cannot attend for example, the book club they attended before, and they lost their identity. So that's some of the social impacts other than language impact on patients with aphasia. And so here is some basic knowledge about AAC. So AAC refers to a set of methods and tools that are used to supplement or replace speech or writing for individuals who have difficulty communicating effectively through like speech or written language. And with the advancement of technology, there are more like technology-based AAC interventions for people with aphasia. So as you can see, some of the pictures I put in here, we have some dedicated device like Linguafica, Touch Talk, and also some applications that you can purchase on App Store. We can use these high-tech AAC communication devices and applications for your patients with aphasia. And so who could be like candidates for AAC? And there are two types of patients that could greatly benefit from using AAC to communicate. And one type is people with chronic severe Broca's aphasia, and also people with global aphasia. So we know that while some patients with aphasia regain speech and language function through restorative therapy approaches, others may continue to have severe communication impairments with little to no functional speech. So let's take a look at some videos of these patients. And the first one is a lady with chronic severe Broca's aphasia. Let's see. So we consider chronic severe aphasia as those patients who are 6 to 12 months onset, and they still they still have limited to no speech, no functional speech. Let me know if you guys can hear the audio.
All right. What is your name?
My name is
Barbara.
Barbara.
Okay. Barbara, what is your address?
Oh, I think is no. Uh, uh, um, I think,
778 route?
yeah.
Okay.
So as you may have noticed, she is characterized as having awkward articulation, also restricted vocabulary, agrammatism, relatively intact auditory and auditory comprehension, and she also demonstrates some levels of writing abilities. And this is a video example of people with chronic severe Broca's aphasia. And the next one is a patient with global aphasia. Okay. Oops.
What do you want to talk about?
Let's see. Okay. It seems I cannot play this video, but it basically showed a patient, like she was just producing articulations like she cannot respond to any of the clinician's questions. So with global aphasia, this patient had multiple lesions in her brain, and a lot of the majority of the language competencies have been like negatively impacted. Okay, so now I'll be talking about the rationale behind AAC implementation for patients with aphasia, like why we can use AAC for them and why they can benefit from it. And here is a research study done by Dr. Cole and his colleague. So in this figure, the take-home point is that, as we can see, the intact ability to, like people with left hemisphere lesions, like people with aphasia, is the square here. And they have intact ability to identify pictures and line drawings with greater ease compared to written words. An individual with aphasia and normal adults, which is the circle in here, do not differ significantly in the recognition of graphic symbols, and their ability of right hemisphere to process graphic symbols suggests that AAC intervention strategies can utilize the intact portion of the brain to communicate more effectively through some graphic symbols. So as we can see, people with right hemisphere lesions, they have way more difficulties identifying symbols. However, for people with aphasia who have left hemisphere lesions, they have comparable performance when identifying like symbols compared to the healthy controls. And also, people with aphasia, they can put together like the level 4 sentences in here, like he can sit and eat using symbols. Although like their ability to produce like grammatically more complex messages have been largely impaired. However, with the help of AAC, they can produce some grammatical sentences at this level. And also here I want to emphasize the importance of implementing AAC early in the treatment of aphasia. So here is an analogy we would always like to use. So in the early stages, for example, in the early stages of physical therapy for individuals with leg or like a hip injuries, we focus on providing support rather than immediate walking training. So this includes offering aids such as like wheelchairs, canes, and handles, ensuring that they don't have to struggle with walking using only their legs. So also, so it's similar story for patients with stroke who can use AAC early in their treatment. So it should be considered as a valuable tool from the very beginning, rather than being seen as a last resort. So using this proactive approach, people with aphasia can communicate effectively their needs, their emotions, and can improve the quality of life and also their overall quality of care. So early AAC implementation is really helpful to facilitate therapy and support progress in language recovery, and as well as their communication skills, their participation in activities. And also here are some more benefits of implementing AAC for patients with aphasia. It can enhance their communication, help with their word retrieval, language formulation, and also provide them with multimodal communication strategies like oops, besides their spoken language, written language, they can like press. We'll be talking about some AAC strategies in a minute. They can point to symbols on a communication board. They can press buttons on a communication application. So provide them with multimodal communication strategies and can largely reduce their frustration, not only for the patients, but also their caregivers. Because it's really frustrating when you cannot understand what your loved ones is trying to convey. And also help them improve their quality of life and largely increase their social engagement. They can go to church to meet their old friends and participate in activities like their book club, and also like maintaining relationships with their families and friends. All right, and now I will be talking about the next topic, which is very important, some considerations while you're planning to implement AAC for patients with aphasia. So these 5 C's for consideration are really important when you begin to implement AAC strategies for your patients and also families. So you need to think about their cultural, their like holidays, and also their food. Those are very important while you are programming like messages, symbols in their devices. And also you want to use AAC to help them improve their language competencies, consider the interaction of the 5 C's, and provide AAC supports to preserve their like communication competencies. And also like counseling here is something I really want to emphasize. So one thing is that the violation of expectation. Let's see. So sometimes you hear people say it wasn't supposed to be like this. And so the person with the disease, as well as their family members, friends, and caregivers, may express this in many different ways. So for clinicians, this is very important for you to consider on the like time horizon of the intervention. So each loss inability or their cognitive, physical, like reinforces the feeling of violation of expectation. And a particularly potent example of this relates to the need for AAC. So the loss of natural speech or the loss of their like written skills as one of their primary mode of communication is a particularly emotional touchstone in any disease process. So it's very important because some people refuse to use AAC or like they're reluctant to adopt AAC options because the loss of the violation of expectations. So it's really important for the clinicians to discuss about this while counseling patients and their family members. And also cognitive decline is something you want to consider while designing your AAC interface. So for example, you don't want to put too many symbols on the interface. You don't want to overwhelm them at the very beginning. And you want to put some words in there that's frequently used by them so that you could give them a sense of mastering the strategies to use AAC from the very beginning. And also caregiver burden, this is also a big thing. So cognitive decline tends to exacerbate caregiver burden. So you also want to counsel their caregivers, also train their caregivers how to best support their loved ones with aphasia. Okay, and now we'll be talking about some strategies, some practical strategies for you to implement AAC in your aphasia intervention for patients. So when we think about language processing, there is actually a two-way interaction. One is like people being a receiver. The other is being like the one to express their ideas. So we'll support patients, we'll support both receptive language and expressive language for patients with aphasia using AAC. And the first one I want to talk about is augmented input. And also Dr. Data has posted an article about, has published an article about this. So the support of any form of linguistic or visual strategies to enhance understanding of language would be called augmented input. Because sometimes, for example, especially for people with like Wernicke's aphasia, they have impaired comprehension. So it would be really helpful if you can write that message down, write the keywords down, or use some visuals to support their language comprehension. So communication partners supplement spoken language with like visuals, like gestures, writing it down, or like drawing to help them better understand what was said. And also clinicians also wants to teach the communication partners to use various augmented input to facilitate effective communication between the caregivers and the patients. And also this is important, you want to teach your patients aphasia to self-advocate, like to let them tell other people, like, can you write it down for me, or can you show me a picture, so that it would improve their comprehension. And here is a video demonstration to show how like an aphasia patient could advocate for themselves. And here is, they go to conversational control and then self-advocacy.
Please print the main words as you say them.
They can have the communication partner to print the main word as they say them.
Can you show me a picture of that?
And also have them to show them a picture to boost their understanding. So that's how you can help your patient to self-advocate, to request for augmented input. Okay. And now we'll be focusing on support expressive language skills for patients with aphasia. And I will be talking about some AAC approaches available for you, and also some considerations while you are designing the AAC interface, and also some AAC intervention strategies, sample activities for patients with different communication needs, participation levels. All right, first one, some AAC approaches. There are some really simple, like no-tech or low-tech AAC strategies for patients with aphasia, like gestures. They could use gestures and writing, signs, drawings, picture books, talking mats, which I'll be giving more details in a minute, and some low-tech communication devices like this, where clinicians or caregivers can record messages, program messages on the device, and patient can press the button to activate the message to convey meaning. And so this is an aphasia ID card. We would suggest that patients with aphasia can carry aphasia ID card with them, so that can improve their independence, and also let the other people, especially those strangers, to know how to better communicate with them. And here is a rating scale, like where like you can use it with your patients with aphasia to have them point at those numbers to express their preferences. And here, this is talking mat. So let's see. So on the top scale here, on the top scale, this allows patients to indicate their general feelings about each topic and option. And the meaning of the visual top scale can be adapted to suit the questions you're asking the person. For example, whether they're happy, here, whether they're unsure or they're unhappy. And topics, like we can select different topics for them, like whatever they want to talk about, and like pictures symbolizing where you live, what do you want to do during the day, or who do you want to spend time with during the day, and then give them options and have them put options under each scale. So this is a talking mat, which you can use with your patients with aphasia. And here are some no-tech communication boards. On the left is a picture board where this one patient can use in the ICU in the beginning of their intervention. Like they could point to the symbols to make requests, to express discomfort, to have them call their caregivers, turn on the TV, something like that. And also on the right is a letterboard for patients who have intact spelling skills or they know the first letters of the word. They can they can point to the letters on the letterboards to spell the word out. So these are some no-tech AAC, very simple no-tech AAC for patients with aphasia. And here are some high-tech options for people with aphasia. This one is the Lingraphica Touch Talk. Lingraphica is a company that designed AAC devices for patients with aphasia. And this is a AAC application called Touch Chat. And this is a specific package communication journey aphasia for patients, specifically designed for patients with aphasia. And everything here is highly customizable. You can individualize the grid size. Now we have a 3x4. You can make it smaller at the beginning for your patients and then gradually increase the grid size to add more symbols on the display. And you can use the symbols or the pictures that the patients are familiar with, and you can program messages that patients frequently used. So everything on these high-tech AAC devices or applications are highly customizable. You always want to customize or individualize the AAC devices for your clients, and also instruct the caregivers how to edit the symbols and how to program messages, how to use it to support patients' receptive and expressive language. Okay. And also here are some free applications also made by Lingraphica, and you can check these out in app stores. So these can be like some small talks, conversational, like I don't understand, or I'm looking for it in on my device, those kind of things. And also this one could be used in the intensive care settings, like I'm in pain, or like if you're frustrated, or I need to be suctioned, like those kind of things. So these are all like free applications, but I don't feel they are highly customizable. You can check these out in the App Store. I also put a web page in here. They have pretty good resources for patients with aphasia at different communication levels. And now I'll be talking about some interface design. So there are two like major interface designs. One is taxonomic grid display, and the other is visual scene display. I will give examples. So this is an example of a taxonomic grid display, which is a visual communication system designed to categorize and also organize information using a grid format. And in a grid display, information is arranged in like a structured grid, typically with rows and columns, and each cell with the grid contains a symbol, a word, or phrase representing a specific category or concept. So it's usually like organized through various topics and ideas in a systematic manner. For example, in a grid display focused on animals, the grid might have rows representing different classes of animals, like mammals, birds, reptiles, and then columns representing specific species within each class. So like the messages are organized within like some syntactic or semantic associations. And here is a video demonstration of how you can use a grid display to activate a message. So here we go to things first, things on the top right, food, lunch, dinner,
spaghetti,
and then spaghetti. So this is how you activate spaghetti. So you go to things first, and then food, and then lunch, dinner, and then
spaghetti,
So then this is a great display, and it's been widely used in many high-tech AAC applications and devices. So this is a, let's see. So this is a AAC application called Proloquo, and it has some verb support, which you can utilize in aphasia intervention to teach patients about inflections. So you can see, like, once you activate a verb, you will see the inflections pop up.
Hi. Go.
Once you select go, and you will see different inflections in here. Go, goes, went, going, gone.
Went. Hi.
So this video, I'm just showing the verb inflections in here. I'm not saying that you have to give so many symbols to your patient at the very beginning. So less options is always good at the beginning, because you only want to include like relevant things in patients' lives, so they feel they can like master using the AAC applications. So there are some really good AAC features that you could use during your aphasia intervention. And also here are some like the semantic associations. In this video demonstration, you will see, let's see, so I went to food, snack, and then salsa. And then you see the pop-up in here, like the different spice levels, hot, medium, mild. So these shows the semantic associations, where you could also use these features to help your aphasia client to improve their like communication competencies on those semantic associations.
Medium.
All right, so that is those are all like dynamic. This is a dynamic grid display. Let's see. So here you see the layout of the messages are very different. So these are visual scene displays. All right. So in visual scene displays, what clinicians or the caregivers can do is to like snap a photo of a meaningful event in the patient's life, or a meaningful area of the patient's life, and then they can, like in here, circle a hotspot, and then they can click edit to program messages in there. And once the patient press the object or the thing, as shown in here, the fridge, and it will activate a message. You will see the labels fridge, and then you can hear the audio fridge. And also in here, once you click on the bathtub, it will speak out the message bathtub. So these are scene displays. So the landscape of the high-tech options for patients with aphasia changed dramatically with the introduction of these kind of visual scene displays. So these visual scene displays are have benefits, because it leverage the retainability of patients to relate to highly contextualized and also personally meaningful pictures, paired with technology of like speech generating devices to create an interface that supports their communication. So it has several advantages. Let me show you guys a video demonstration first, and then we'll be talking about the benefits. My scenes, bathroom,
bathtub,
touch the bathtub, and then activate the message. So this is a different display called scene display, and it actually has a lot of benefits, because it built upon reduced navigation and also rely on patient's episodic memory and provide pretty rich contextual cues for patients to activate messages. So they actually largely reduce the cognitive load for aphasia clients, aphasia patients to activate messages. All right. So lastly, I will be talking about AAC intervention based on patients' communication needs, competencies, and as well as their participation levels. So Garrett Lasker and Dr. Gottman and Dr. Cole, they categorized this patients with aphasia into these two major categories and also the 6 subcategories based on patients' communication needs, competencies, and participation levels. So the first type of communicators we're talking about in here are emerging communicators. So they are patients with like global aphasia who have limited to no functional speech at their acute stages of recovering. They have difficulty in responding to speech or using symbols. So provide AAC systems. So we would like to provide AAC systems designed to meet their basic needs and choices. And it's very important to do the communication partner training at this time because they highly rely on their partners to convey messages. And so here is an example. For example, communication partner would say, do you want to eat a snack or get something to drink? And then present the pictures for the patients to select. And then patients can point to the drink, and then communication partner could continue to ask, do you want milk or juice? And continue to provide some visual supports. So these are emerging communicators, and the initial goals is to communicate affirmations with, for example, a head nod or refusal with a head shake to establish some like consistent communication affirmations with them, to have them choose items, to choose pictured items, and during like functional activities. And also they can participate in some simple board games. Some sample activities like choosing items to meet daily needs, such as shirts, pants, by pointing or having them reaching those items, or create a simple scrapbook and participate in reminiscing like activities, and then signal affirmation and rejection during choice-making activities. And the partners have to use augmented input strategies to boost their comprehension. And the next one is contextual choice communicators. So these always include patients with chronic severe Broca's aphasia or transcortical motor aphasia, or some patients with severe Wernicke's aphasia. They are able to recognize visual symbols and indicate basic needs. However, they are unable to initiate communication and are socially isolated. So they're still like partner dependent communicators. Their speech is like pretty limited. So we have to provide them with AAC strategies that allow participation in controlled, predictable with like rich contextual cues. So for example, we can ask them like, what did you eat for lunch yesterday? And then we write down some options for them, like chicken, steak, peanut butter, and crackers. And they could point to the like turkey sandwich, and then they point to turkey sandwich. So that's the contextual choice communicators. So the initial goals is establish a basic communication system. For example, using like written language or using talking mat. We would like them to we can communicate with them some biographical and specific information by pointing to contextual written choices, or we could also have them indicate their preferences on rating scales or the talking mats. Some sample activities include naturalistic communication situations in the patient's unit and asking questions during individual speech sessions, communication group sessions, or family training sessions. And we always want to talk about like familiar themes, familiar topics to provide rich contextual cues for them to like process information. And also role play is a very good therapy activity because they have a theme, they're pretty familiar with the theme and the context. It would be easier for them to understand the other's language and also generate their response. And the next one is transitional communicators. So they are progressing towards independent communicators, and they're able to generate some novel and stored messages without partner support. However, they still depend on cues and prompts to stay engaged in spontaneous conversation. So here is an example of an interaction using like pre-stored messages on the speech generated devices. For example, the patient could say like, the communication partner say like, I like chicken fajitas, and then the AAC user, her speech, she can only say, oh yes, and then she's able to find a stored message on her device saying like, I want to eat at the steak place. So this is an example of an interaction between a communication partner and a transitional communicators. And now we'll be moving on to partner independent communicators. So these patients do have some severe expressive speech and language issues. However, they have relatively adequate comprehension. They are usually patients with moderate to severe Broca's aphasia, transcortical motor aphasia, and conduction aphasia. So the first one is stored message communicators. So they are able to use their AAC system to supplement their limited speech independently, and their retrieval and use of messages stored in their devices, and their ability to use their devices to communicate novel information in unfamiliar context is still limited. So we call them stored message communicators. So it would be easy for them to produce some stored messages in familiar contexts. For example, when a volunteer asks the patient, what is your name? And she has difficulty producing her name, and she's able to activate a message in her device saying like, my name is Susan Smith. So this is a stored message communicators. They can independently generate stored messages in their device. And the next level is generative message communicators. As you can tell from the name, they're able to communicate independently in different settings using like either limited speech or writing, and they're able to generate novel messages using their like AAC systems. However, they need substantial instruction as well as practice to like use some like strategic methods to also like generate novel messages in various settings. For example, as we can see this lady, she can use her speech generating device to supplement her speech around those people who rarely or never spoke on a regular basis. And she can use her speech generating device to spell out like short words or the first few letters of long words. So she did not only rely on the stored messages in her device, but she can generate some like novel messages using her device. This is what we call generative message communicators. And the last type we're talking about in here are specific need communicators. So they still have some like mild to moderate symptoms, and but they are able to use some like to produce some simple sentences on their own. They need some communication support in like specific situations. For example, this lady, she has pretty severe word finding issues, so she can use the word prediction function in her speech generating device to produce words that she had difficulty retrieving. And also, we have an example here saying like, we have another, wait a second. I have another example. Okay. So for example, another patient, like she wants to give a toast on her sister's wedding, and she want so like she can like practice her toast with her speech language pathologist, and her speech language pathologist could program some messages in her device to help her give a like a more like fluent speech toast in her sister's wedding. So those kind of patients, they need communication support in specific situations. We call them specific need communicators. All right, so that's the end of my presentation. Here are some take-home messages from my presentation. The first one is that thank you to the advancement of technology. Thanks to the technology advancement, high-tech AAC interventions have become more and more available for people with aphasia. And we would suggest that you implement AAC early in the treatment of aphasia rather than being seen as a last resort. And also, we have research showing that individuals with global aphasia, severe Broca's aphasia, who have limited to no functional speech, they're able to use speech generating devices or AAC devices to access, manipulate, and combine symbols to produce sentences and phrases. So, and the use of visual scene displays can largely decrease cognitive load by reducing demands on patients like navigation, episodic memory, and providing more contextual cues for them to produce messages. So, and also AAC intervention that involves multimodal communication strategies can largely enhance communicative effectiveness and the efficiency of patients with aphasia, can decrease their frustration as well as the caregiver's frustration. AAC tools, materials, intervention strategies have to be individualized based on the patient's communication needs, competencies, their participation levels, the specific activities they would like to participate in life. And also we would suggest that you do like an ongoing AAC assessment and intervention for your patients as they progress. Okay, all right, that's the end of my presentation. Any questions for me?